Good evening, friends. Today we are discussing some image-based questions in orthopedics. So let us start with it. Now, the first question I would like to discuss, and this has been asked in one of the exams previously also, is which of the following nerves can be injured in this deformity? Now, if you see here, this deformity, the first thing is to identify what deformity this is. So this is a cubitus valgus deformity because the carrying angle of the forearm with respect to the arm is increased in a valgoid manner. So this is a cubitus valgus deformity. Now if you can remember, the ulnar nerve crosses the medial epicondyle. The ulnar nerve passes behind the medial epicondyle. So in cases of a cubitus valgus deformity, there is a continuous stretch on the ulnar nerve, and this leads to something known as a tardy ulnar nerve palsy. Tardy means slow. So this palsy develops over a course of a variable period of 2 to 20 years. So tardy or slow onset ulnar nerve palsy, late onset ulnar nerve palsy in this case is the best option to be marked. Coming on to the next question. Now the question here is, what treatment should be given for this child? Now, as we all know, the x-rays should be approached systematically. So if we go from distal to the proximal end, or if we go from the joint away from it, what we see here is that this is an x-ray of a skeletally immature patient because the physis has not fused yet. Also, what you can see in the x-ray at the end is there is splaying, fraying and cupping of the physis. Now these are characteristic of rickets. And we all know that for treatment of rickets, which is a vitamin D deficiency state in children, the best option to be marked is vitamin D because that should be given for the treatment of this child. So this is an X-ray image of rickets, and the best treatment modality is giving vitamin D. Coming on to the next question, here we have an image depicting a periosteal reaction which has been marked, and the question asks the following radiological feature is associated with. So in this, if you can see that the periosteal reaction is diaphyseal. So that should give you the first hint as to what this condition can be. Now, if you can see in this image, the reaction is in the form of various layers of periosteum laid over each other. Now this layered reaction of the periosteum laid one layer over the other is known as an onion peel appearance. So a diaphyseal tumor with an onion peel appearance, the most likely diagnosis should be Ewing sarcoma, and that is the best option to be marked in this scenario. Coming over to the next question, the question asks most likely diagnosis in this X-ray is. Now again we should approach X-ray in a systematic manner, so we should go from below inwards or from the joint and away from the joint. In either case, what you see here is that in this picture, this is the femoral capital epiphysis, this is the femoral neck, and this is the femoral shaft. And in this picture on the opposite side, what you can see is the femoral shaft can be appreciated, the femoral neck can barely be appreciated, but the femoral capital physis is missing. Now, femoral capital physis can be missing in cases where there is an infection of the joint which leads to destruction of the joint and hence can cause an absence of the femoral capital physis and hypermobility. Absence of capital epiphysis. Now, if you see in Perthes disease, there is an idiopathic AVN of the physis. In this scenario, the femoral capital epiphysis will be narrowed and will give you a picture as if it is broken at multiple places, but it will not be absent. Now, in a case of dislocated hip or developmental dysplasia of hip joint, what you will see is that the femoral capital physis is upridden and out of the acetabular cavity, but not absent. In rickets, what you will see is that the femoral capital physis will essentially be normal. However, there will be some changes in the metaphyseal or the physeal region. In Tom Smith arthritis, what happens is that it is basically a septic arthritis of infancy in which the femoral capital physis gets eaten up by the bacteria and it will be absent on an X-ray. So the best answer in this scenario will be the Tom Smith arthritis. So the next question, we actually have a combination of two questions here, because in this image, the examiner asks you what is the most common presenting symptom of this disease. Now, for identifying the most common presenting symptom, you have to first identify what disease this is. Now, if you can see here, this is basically a fused spine, which is like a bamboo stick, and this is known as a bamboo spine. Now, a bamboo spine is characteristic of what is known as the ankylosing spondylosis or ankylosing spondylitis. Also, what you can see in this image is that the spinous processes are seen in a one continuous line, and this is something which is known as a dagger sign. Again, a characteristic of ankylosing spondylitis. So now that we have made a diagnosis from our image, the next part of the question is that what is the most common presenting symptom? And the most common presenting symptom or the first symptom to strike in a case of ankylosing spondylosis is that the patient develops sacroiliitis, which usually presents as low back ache as its first symptom. So in this case, low back ache is the best option. Now, pain in hip region can also be the answer, but that develops rather late because the hip joint in ankylosing spondylitis is definitely affected, but a bit later on in the disease pathology. Difficulty in breathing can also be a symptom of ankylosing spondylitis because difficulty in breathing is caused by a decreased expansion of the chest. However, this is also a late symptom. Stiffness of the back can also be a symptom, but this is not the first or the presenting symptom. The presenting symptom usually is low back ache. Now, coming on to the next question. This question asks the nerve injury associated with this fracture can be. Now, this is a question which involves the anatomy, the knowledge of orthopedics, and the knowledge of diagnosing this disease first. So, in this picture, if you can see, there is a fracture of the ulna right here, proximal third part of the ulna. Now, if you see the radial head here, as we have discussed in our lectures, a line passing through the radius should pass through the capitulum. So a line passing through the radius should pass through the capitulum. Now, if that does not happen, that means that the radial head is not in its normal position and there is dislocation of the radial head. So radial head dislocation with fracture of the proximal third ulna is seen in a Monteggia fracture dislocation. Now, coming on to the second part of the question, the examiner wants you to tell which nerve can be associated with this fracture. Now, anterior interosseous nerve, which is a branch of the median nerve, passes in the forearm, and its course is such that it can be impinged upon or damaged due to the fragment of the ulna, which is dislocating anteriorly in this case. So the best option in this case should be anterior interosseous nerve. Coming on to the next question, the examiner asked what the following test is used to identify the injury to which of the following structures. Now, if you remember, in the knee joint, we have ligaments and we have menisci. The ligaments are responsible for providing stability to the knee joint, and this test is known as anterior drawer test, in which the examiner puts an anterior strain on the tibia to see the tibial translation over the femur. Now, this test, if positive, because we know that anterior cruciate ligament is the structure which stabilizes and prevents the tibial translation anteriorly over the femur. If this ACL is injured, this test, which is the anterior drawer test, will be positive. So the best answer in this scenario is the anterior cruciate ligament. Another test which is used to diagnose the same condition is the Lachman test, and this is also something which has been asked. Coming on to the next question, the examiner wants you to tell that this condition is commonly seen in. Now, to diagnose this, first we have to see what condition this is, only then can we reach to any conclusive answers. Now, if you can see in this image, there are multiple swellings and discharges from those swellings. The most likely diagnosis in this scenario is Madura foot, which is caused by actino or eumyces. Now, Madura foot is commonly seen in injuries in farm workers, where when they walk bare feet on the floor or the fields, the thorns can get in and breach the body and the infection can set in, and hence farm workers happens to be the best answer in this scenario. So this is a picture of a Madura foot, and farm workers or peasants or farmers are the most commonly affected individuals in this scenario. Now, this next question asks, X-ray wrist is showing a soap bubble appearance in the epiphyseal region. What is the most likely diagnosis? So, there are three things which are there in this question. The first is that the examiner wants to know that this is an X-ray of the wrist joint and the distal radius is involved in this. Also, they wanted to know that this is an epiphyseal involving lesion. So epiphyseal involving lesions are also commonly giant cell tumors, particularly in the region of distal radius. Now, soap bubble appearance, the third hint towards the diagnosis is this soap bubble appearance, which is seen in this X-ray, and all these points towards the giant cell tumor, which is the right answer in this. Now, this question asks what structure fracture in this scenario can lead to. If you see carefully here, this happens to be the clavicle and this is the first rib. So in this image-based question, what they have depicted is the fracture of the first rib, which you can see here. Now, first rib fractures are notorious because they usually happen in high velocity injuries. First rib is not fractured easily and it takes a high velocity injury to fracture the rib. And in cases of first rib fractures, there is a very high likelihood of associated visceral injuries also. What is important to remember is that the first rib lies in close proximity or lies rather just underneath the brachial plexus, the subclavian artery, and hence any injury to the first rib can injure brachial plexus as well as the subclavian artery. Now, in first rib fracture recoveries also, the Horner syndrome is a common association. So in this scenario, the best answer is all of the above. So a first rib fracture is usually a high velocity injuries associated with other visceral injuries, as well as it can present with a brachial plexus subclavian vessel injury.